Our knowledge and truth for a healthy living is a must. Here are the experts. Here are the facts. Here is what we testify to and speak. This is Shop Talk.
Good morning and welcome to another edition of the Shop Talk. We are here in downtown Atlanta at the Purple Door Salon. I want to thank our host, Dwight Eubanks, for granting us another opportunity to be able to record and live stream Shop Talk. We're here today because it's Prostate Cancer Awareness Month. And our objective today is to be able to reflect on the issues relating to prostate cancer in Black America and why the burden of disease, mortality, why it's higher than what we think it ought to be. And in order to be able to do that, we have a panel, a special panel that I'm really excited joining us this morning to be able to shed some more light on these issues. We have Dr. Simbo Aduloju, who is a hematologist oncologist here in Atlanta, practices with Northside, and he's been there with them since 2009, having completed his residency at Emory University, where he also did his fellowship. Medical school was in New York, and he was also the chief fellow during his residency year. He's one of the providers of specialists that I collaborate with very well in my practice. I'm a primary care physician here in Atlanta, and his specialty area is GU oncology. That's everything relating to genitourinary system is his area of specialty. And he's a member of the American Society of Clinical Oncologists. Dr. Simbo Aduloju, thank you so much for joining us this morning. We'll look forward to your insight and your expertise.
Happy to be here.
Thank you so much. And we also have Dr. Janelle Foote, who is a practicing urologist here in Atlanta. She's the vice president of Midtown Urology and Midtown Urology Surgical Center in Atlanta, originally from Ohio. And she went to the West Coast for medical school, was at University of Colorado. Also was in LA, in Los Angeles, where he also did practice at the Casa Permanente in Los Angeles. She's a board-certified female pelvic medicine and reconstructive surgeon, as well as in urology. She's a member of the board of American Board of Urology, Fellowship of American College of Surgeons, the Society of Female Urology and Urodynamics, the International Society for the Study of Sexual Health in Women, the National Medical Association, and the Society of Women in Urology. She has been honored severally with many awards, which includes the Continence Champion for the National Association for Continence. And she's been featured in the Atlanta's magazine of Best Doctors in 2023 and 2024. She is passionate about education and is a clinical assistant professor at Emory University of Medicine, where she's a recipient of teaching awards in 1997 and 2021. She has received additional teaching awards also from Morehouse School of Medicine and Atlanta Medical Center. She's also a principal investigator with some of clinical trials that is over at the Shepherd Spine Center. Dr. Janelle Foote, thank you so much for joining us this morning.
Thanks for inviting me.
Thank you so much. And we have remotely joining us Dr. James Benton. This is one of the things that came out of COVID, where we now know that connectivity is something that has gotten to a different level. So if someone can't join us in person, is able to join us remotely. Dr. Benton, we thank you so much for joining us. He's a board-certified radiation oncologist and a member of the American Board of Radiology. He believes in providing quality and personalized care in a community setting and demonstrates commitment to daily care of his patients. He's a magna cum laude graduate from the Armstrong State University in Savannah, Georgia, with a bachelor's in chemistry and math. And he also attended Morehouse School of Medicine, where he completed his medical degree and graduated as the valedictorian of his class. He completed residence in internal medicine at the Medical College of Virginia and his second residence in radiation oncology at Emory University, where he was also a chief resident. He's practiced here in Atlanta for well over 22 years. He's currently the president of the radiotherapy clinics of Georgia, and practices at their main campus in Decatur, specializing in treating a variety of cancers such as breast, gastrointestinal, lung, skin, and many others. He also performs a unique treatment for prostate cancer, which I'm sure is going to speak to us about later on this morning. Along with other experts in the field of prostate cancer treatment, Dr. Benton has authored numerous medical research manuscripts, and his work has been published in numerous peer-reviewed journals. Dr. James Benton, thank you so much for joining us this morning. Let's hear your voice and give us a thumbs up that we can see you and you can hear us clearly.
Well, I'm happy to join you all here remotely.
Thank you so much. So let's dive into our conversation this morning. And Dr. Aduloju, if you want to take the lead, or maybe let's actually start with Dr. Foote. What is the prostate gland, and what does it do? Why is it important? Of course, we know that the prostate gland is a gland that only men have, not women. So what does the prostate gland do? What is it?
Well, the prostate is very important. Without the prostate, there'd be no people on Earth. It's not an exaggeration. The prostate is a gland that makes the fluid that the sperm sits in, helps the sperm stay alive, helps the sperm to be able to do their work. After the sperm is made in the testicle, it travels in a little tube called the vas deferens, all the way inside of the body to land at the prostate. Where the prostate sits is right in between where the bladder is and the urethra, the tube where the urine comes out. And that's why urine goes through the prostate and semen goes through the prostate too. So I'm not exaggerating when I said that the prostate is important for people to be here, because that's how a man gets his fertility. When a man ejaculates, the fluid from the prostate gets with the sperm and it goes all kind of together like a milkshake. And that's when it comes out, and that's what makes a man fertile. The prostate is also important for urination because it has a channel through it that the urine goes through. This is why if men are having trouble with their prostate, the channel is too tight, for example, a man will have trouble urinating. The prostate is one of those organs that's kind of silent, doesn't really know that it's causing a trouble unless it is in trouble. Kinds of symptoms men have from their prostate include the urine not coming out fast enough, having to get up a lot at night, blood in the urine or the semen, also pain. The pain the prostate feels sometimes is by the rectum because the prostate on its backside has the rectal wall. So that's what the prostate does. It's really important for a lot of the things that men do, and keeping it healthy is important too. One of the things I love so much about your seminars is that you promote being proactive about health, and you promote about how to keep things healthy. So I'll just say a few words about keeping your prostate healthy. Because it's a gland and it makes fluid, making fluid is what it does. So when a man ejaculates, you're kind of exercising your prostate. So I tell men frequent ejaculation is a good thing. The other thing is that you need to give your prostate the nutrients that it needs. It needs various minerals, including magnesium and zinc. You're going to get those if you eat a good plant-based diet. Meat's okay, it's got protein, it's wonderful, and it has minerals too. But keep in mind that your fruits and vegetables, particularly the ones that are yellow, red, and orange, have special chemicals that keep your prostate healthy. Adequate fluid intake is important too, because that makes the urine that actually washes out the prostate on a regular basis. Urination on a regular basis is important. Holding it for long periods of time can make the prostate sick because it doesn't get to do what it needs to do. So frequent urination is helpful too for the prostate. Avoiding certain activities that may put excessive pressure on the prostate is something else to keep in mind. If you are a long-distance bicycle rider or have other types of activities that put a lot of pressure on your perineum, Try to make sure that you have a seat that's adequately padded, because if you have one of those skinny seats, you're putting all the pressure from the top of your head to the bottom of your body, all concentrated on your prostate, and that can cause issues too. So, in a nutshell, that's what the prostate does, and that's how you keep it healthy.
Thank you so much, Dr. Foote. And so the prostate it weighs about 1 ounce. If you put 5 quarters together, that is what the prostate is like. It's amazing that something so little can cause us so much pain and trouble. One of the reasons why we're here today, focusing on prostate cancer issues, we know that prostate cancer, 1 in 6 African American men will have prostate cancer in their lifetime. If you look at the rest of the population, it's 1 in 8 that will have prostate cancer in their lifetime. So meaning that many more African American men relatively will be diagnosed with prostate cancer in their lifetime. So Dr. Simbo Adeloju, what is prostate cancer? As a cancer specialist, and I know you deal with this all the time, when people hear that C word, it sends shivers down people's spines. What is cancer, and what is prostate cancer, and what is that burden in the Black community in terms of numbers?
Right. So thank you for this opportunity again, Dr. Akintobi. So prostate cancer and cancer in general, when you look at the body, there are certain rules that needs to be followed. If you look at your skin is smooth, it doesn't look rough, and there are certain changes that individual tissue in the body goes through. And this is what we call turnover. There's a lot of turnover going on within different tissues in the body. So cancer in general is usually when there is a specific mistake in some of these turnover processes, to keep it simple. And now the new tissue, or cell as we call it, now is behaving on its own. It doesn't follow the rules anymore. It's supposed to line up in certain ways to make it uniform. Now, because it's not following any rules, it's just organizing itself in a very unorganized manner. And that, at the end of the day, leads to what we refer to as tumors. And, prostate cancer in general, as Dr. Akintobi has said, it's about 1 in 6 African-American male in the United States over their lifetime. And the burden of disease in the African-American community is high. And the incidence of prostate cancer in the African-American community basically predates PSA. As we just earlier stated, 1 in 8 in the general population in America in a lifetime, and 1 in 6 in the African-American men in their lifetime. And what we've seen is that the burden of the disease tends to be higher. African-American men are more likely to be diagnosed with advanced stage disease. And if they're not diagnosed with advanced stage disease, they're more diagnosed with a more aggressive form of disease, which we're going to go into as the conversation goes on. So it's a big burden in the African-American community, and it's something that is definitely worth talking about and creating a significant awareness to.
Mm-hmm. Thank you so much, Dr. Simbo. And we're going to bring you in, Dr. Benton. We know that this year, over 300,000 men will be diagnosed with prostate cancer. That is the size of the city of Savannah.
That's my hometown.
There you go. So that's why I'm coming to you. Of those, 35,000 will die from prostate cancer this year. Of the 35,000 that will die from prostate cancer this year, 7,000 will be African-American men. So we're saying that, in other words, over 20% of folks that die from prostate cancer in America are Black men. Yet we only make up about, 14% Black people of the total population in America. So we know too that if you look at the total diagnosis, that prostate cancer is the number one diagnosed cancer in men, in black men in America, but it is lung cancer is the number one cause of cancer death. So many more men may be surviving prostate cancer than we have in the past.
Yes.
So just looking at those numbers, why are we where we are?
Yes, well, you know, one of the interests of myself and my partner, Dr. Bennett, and many other researchers has been why this disparity in the incidence of prostate cancer and why are there more aggressive forms of prostate cancer, more fatal forms of prostate cancer in our population. There are a variety of factors. There are many environmental factors, meaning factors that happen from outside of us in our communities and in our bodies that may explain this higher risk. One of them is the risk of being exposed to certain toxins. African Americans may have a higher risk of exposure to toxins because of environmental toxins. I was just reading that there was a bill in the legislature in Louisiana, for example, looking at so-called Cancer Alley. You're familiar with that, where African American communities are disproportionately represented in areas where there are factories and so forth involved in the petroleum industry that spew all kinds of toxins that are in the water and in the soil and in our air. All of us are exposed to toxins, but if one lives in a community that has more toxins in the environment or has a job that involves exposure to more toxins. For example, someone who's a welder, who works in the automotive industry, who works around exhaust, works in a factory where there's a lot of exhaust and fumes, that person will be at high risk for many cancers, and I think you have certainly seen that in your work. So that those are all increased risk factors. There are some factors that we believe are genetic. As one of the interesting facts, we've been talking about African American men. Really, African men from Africa, as well as the diaspora, appear to be at higher risk of prostate cancer as well. So certainly there's some environmental factors. Dietary factors, I talked earlier about what's a healthy diet for the prostate. It appears that a diet that's higher in red meat, in charcoal meats, and I know I'm saying this the weekend after Labor Day, is associated with more evidence of prostate cancer. For example, some of you may have friends and family who are vegetarian or Seventh-day Adventist. Seventh-day Adventists, or have been studies done showing that their risk of prostate cancer is low. There are studies looking at Japanese men, Japanese men in Japan eating a traditional Japanese diet, then coming to this country, demonstrating that the risk of prostate cancer in Japan among men eating a traditional Japanese diet is low. When they immigrate to this country, the incidence goes up and mirrors that of the typical American. So there are a number of factors to include that. Stress, environmental stress we talked about, emotional stress can yield increased risk of all types of cancers. There's some work, we did a study at Midtown Urology some years ago looking at vitamin D levels. We became interested in that, demonstrating that low vitamin D levels, if a man does get prostate cancer, an African American man specifically, the risk of having a more aggressive form of prostate cancer is higher. For that reason, we're checking vitamin D levels on all of our men because we want to be proactive. If a vitamin D level is less than 30, we supplement it. And we are hopeful that that is potentially going to decrease the risk of more aggressive forms of prostate cancer. There's a study at Johns Hopkins, for example, looking at recurrence rates of prostate cancer with vitamin D. And it does appear that vitamin D supplementation is helpful in regards to decreasing the risk of recurrent prostate cancer. So that's another tip, being proactive for your audience out there and for your patients. Know what your vitamin D is. As people of color, vitamin D comes from the sun. As the sun hits our skin, there's chemicals in our skin that convert it to vitamin D. Keep in mind that we have natural sunscreen, which is good for skin cancer, but our absorption and the transference to vitamin D may be lower. So.
Thank you so much, Dr. Foote. Dr. Benson, can you hear us now?
I can hear you. Can you hear me?
Yes, we
Yes.
can. So if you want to go ahead, we laid that the question on the table is about the fact that about 300,000 men will be diagnosed with prostate cancer this year. 35,000 will die from prostate cancer. Of those, 7,000 will be African American men. Why is the burden of disease, in your opinion, higher amongst black men? Just in terms of the numbers. We're also going to come back and talk about the nature of the disease when it's diagnosed and the staging of the disease when it's diagnosed.
Thanks for the question and thanks for the invite. Yeah, I think we all know the statistics, men of African heritage, and I'm going to say that term intentionally, that is, men of African heritage have about an 80% chance more likely to get prostate cancer and 220% chance of more succumbing to it. There are all kinds of theories out there, but if you look globally, there are north of 8 billion people on the planet. And during the course of a human lifespan, 1/3 of human beings will develop some type of cancer. And certain ethnic groups will have a proclivity, if you will, to develop certain types of cancers. For example, Ashkenazi Jewish women have a high burden of developing certain types of breast cancer. Chinese men, especially in southern China, have a high incidence of developing nasopharyngeal cancer because they smoke their herring fish, and that smoke may have some carcinogens. And men of African heritage, ours happens to be prostate cancer. Now, I want to caution, because this is a little bit controversial, but how do we define race, the black race or white race? Is it biology, or is it a social construct, or is it a social political category? And the reason I bring that up, because most of the cancer burden are from men from have ancestry from Northwest Sub-Saharan Africa. Men in East Africa and South Africa, the prevalence of prostate cancer is slightly lower than Europeans. So it's more than just the biology, it could be regional. And the other thing I really want to talk about, because early detection is the equalizer. Whether you're talking about prostate cancer or any cancer, we don't have many markers to identify cancers, but we do have the PSA, prostate-specific antigen, and it is a slightly misnomer because we can find PSA sometimes in breast tissue or endometrial tissue, so it's not necessarily specific, but most of the PSA will come from the prostate or the seminal vesicles. So early detection, we tend to look at the PSA of being 4 or higher. That may not be correct in African American men. There was a large study, a very large study, from Utah VA, of all places in Utah, but it was a national study. 280,000 men, veterans, all veterans. And the reason they did the veterans, because they have equal access to care, so you can take that out of the equation. 75,000 of those men were men of African heritage. Just over 200,000 were white men. And they did something very interesting in the study. They look at pre-biopsy PSA to determine the predictive value of having prostate cancer. And this is what was alarming from that study. If an African American man or men of African heritage had a PSA of 4.0, that was almost equivalent to a white man having a PSA of 13.4, which means that we should probably start screening African American men at a much earlier PSA cutoff. For example, if you have a PSA of 2.5, that may means that the PSA is equivalent to a white man of having one of 8.75. So early detection is the key. Now, could there be some biological features that could possibly be, but there are other confounding factors in terms of why African American men or men of African heritage are dying disproportionately to white men. It could be access to health care. It could be that men are waiting until they're having symptoms. For a variety of reasons, some African American men may have some suspicion, and Dr. Foote and Dr. Adebayo may see this in their practice because of the history of medicine in this practice. And I mentioned one word, Tuskegee. And so there are a number of factors in terms of why it's such a disproportionate mortality between men of African heritage and European men. But I think one of the key is scientists and insurance companies, we need to drop that cutoff for which will trigger a biopsy in African American men, because the earlier you detect cancer, and it is self-evident, early detection saves lives. If you detect cancer in its infancy before the horses have left the barn, then the outcome's gonna be much better. And one last point I want to make here. There is something called a liquid biopsy test that we don't use, but I have been trying to use in my practice and trying to get insurance to pay for it. It's called the ExoDx, ExoDx. Exo is short for exosome. Exosomes are extracellular proteins that carries DNA and RNA. That test was approved by the FDA in 2019. So if you have a PSA between 2.0 and 10.0, it's a urine test. You pee in a cup, and there's a cutoff value. That cutoff value is 15.6. So if your ExoDx is greater than 15.6, there's a very high probability that you have a clinically significant prostate cancer. And what I'm trying to say is that we need to test early, as opposed to waiting until the PSA becomes 4.0, because the PSA is a very good test, but it's not a perfect test. The sensitivity is not that high. The specificity is high because there could be other factors associated. But I think testing early in African American men is the key to try to balance this mortality differential between men of African heritage and European men.
Thank you so much, Dr. Benton. And for our viewers, Dr. Adebayo, I want us to clarify what does the PSA mean? The points that were raised by Dr. Benton about the importance of early diagnosis, we do know that for African American men, for men in general, if your prostate cancer is diagnosed early, you have a 5-year survival of 99%. And you can look at the way the prostate cancer staging is such that you can have everything localized, everything is contained within the prostate, or it may have spread just a little bit outside of the prostate, which is called a regional spread, or it could have gone all the way out to other organs in the body. So for the purpose of our viewers and listeners here, Dr. Adebayo, I want you to tell us what is the PSA, what is the importance of that, and secondly, to tell us the staging. How do you stage prostate cancer? If Mr. X comes and he has early stage prostate cancer versus Mr. Y that has a later stage, how do you make that distinction? So what is PSA and how do you stage prostate cancer?
Prostate cancer, yes. So PSA, as Dr. Benton has alluded to earlier, is a prostatic specific antigen. Basically, there are a lot of what we call proteins in the body, and certain tissues are known for making more of a particular protein more than another tissue. So the idea of a PSA is to say that this particular protein is mainly produced by the prostate, and when the prostate is in distress for whatever reason, cancerous process, infection, as Dr. Foote has alluded to earlier, that now that particular gland is shedding a lot of that protein into the blood for us to measure. So in the setting of prostate cancer, like I said earlier, there's disorganization that goes on with cancer. So now the tissues are no longer following normal rules, and they're producing a lot of this specific protein for the doctors to pick up in the blood. So that's how you could, of course, as Dr. Benton is alluding to earlier, we could debate what's going to be the cutoff point for the PSA for us to intervene. But the general idea is there is some form of disorganization going on a tissue level in the prostate, and there's more of this protein being released into the blood. To speak of, staging in a nutshell of any cancer is to determine, is the cancer still contained in the organ within which the cancer started. So in the state of prostate cancer, obviously there are localized disease, which basically indicates that the cancer starts within the prostate and is still localized to the prostate. There are other factors to look at, as the cancer moves to all the regions of the prostate, or is it on one direction or one area of the prostate rather than both sides. And then there are other elements around the prostate, which we refer to as the lymph nodes. The lymph nodes are part of the immune system, mainly, that helps to filter the body and help defend against certain kind of infection. So the lymph node is always a very, very vulnerable state where some of these cancer cells could actually escape the prostate and move to this lymph node. And then, of course, in a much more what we call advanced state, where now the prostate cancer is left, the prostate is left the lymph node and is gone entirely to a different organ. So a different organ, most commonly the bones. We've seen it everywhere. You could go to the liver, you could go to the lungs, practically you could go any part of the body. So in a nutshell, that's kind of how we look at staging. How far has the cancer gone beyond the organ within which the cancer started?
Thank you so much, Dr. Adeloju. So for African American men, 84% of prostate cancer is diagnosed in the localized state, meaning the prostate cancer is still right there within the prostate. As a primary care physician, of course, my responsibility when we have patients come through, when they do their annual physical, is to do that simple blood test. It's a simple blood test where we take the blood and we, just like we're checking your blood sugar, we can check the PSA. The PSA for men, the standard in terms of numbers, 0 to 4 is normal, but there is argument and conversation, as a panelist have said, that for African American men, maybe that cutoff needs to be a little bit lower at 2.5. And conversations with Dr. Adeloju in the past, he has seen PSAs as high as 40,000 when it's supposed to be 0. And I'm sure Dr. Foote will also tell us how high the PSAs that she's seen. So when we do that blood draw and the PSA is high, say somebody comes in with a PSA of 10, the question then is, what is the next step? Where do we go from there? As the urologist on the panel, Dr. Foote, walk us through the process. We send somebody to you. I say, Dr. Foote, we have a gentleman whose PSA is 9. Where do we go from there in terms of being able to make a diagnosis? Are we talking every PSA that is elevated? Does it mean prostate cancer? Are there other conditions that can influence the PSA? But walk us through the process of diagnosing prostate cancer in your practice.
Yeah, that's a really good question and very timely too. For a PSA at our practice, we recommend screening after age 40 for men who have African heritage and any man who has a family history, meaning a primary person in their family, a father, an uncle, a brother with prostate cancer, because the higher risk. Our cutoff is 2.5. And under that circumstance, if a man comes with a PSA is over 2.5 or is 8 or 9, as you've mentioned, we look to see are there any other things happening in the body that can be responsible for that elevated PSA. We do a rectal examination to get an assessment while the patient's in the practice about how big the prostate is. A big prostate is going to make more PSA even without cancer. We also want to understand if there's any infection or inflammation of the prostate. We're going to want to look at the urine. We're going to want to see if there's any evidence of infection. If there is evidence of infection, for example, the man has some burning with urination, there are cells in the urine like bacteria and white cells that we suspect infection. Under that circumstance, we're going to want to treat that infection and have the guy come back. We're also going to ask, do you remember the last time you ejaculated when you gave that, had that blood test done? There's evidence that suggests that if a man has ejaculated within 3 days of having that blood test, that PSA may be slightly elevated. The other sorts of things we look at is to see how significant is it that elevated PSA is cancer, right? That's the million-dollar question.
That's correct.
Dr. Benton, you mentioned the XODX. We use that very commonly in our practice. If the PSA is equivocal, say between 2.5 and 8 or 9, for example, particularly if a man is not really excited about having a biopsy, even though we might maybe feel a nodule on the prostate on an exam and so forth. The XODX, you're absolutely right, is an excellent way to try to stratify those men, with a level between 15 and 100 being at a higher risk of actually finding prostate cancer in the prostate gland, with having a level less than 15 being less likely associated with prostate cancer. If we recommend a biopsy to a man for prostate cancer, we want to be more certain that it's going to yield something. Now, when we biopsy the prostate, there's different ways to do the biopsy. Probably the most common way that biopsies are done in this country is transrectal. As I mentioned before, the back of the prostate is immediately next to the rectal wall. A transrectal biopsy means that a tiny needle is used to go through the rectal wall into the prostate to get pieces of the prostate to look at under the microscope. Many times we use some type of imaging guidance to guide us to where the area is going to be most likely to find the prostate cancer. Because in a way, it's kind of like a needle in a haystack kind of thing, right? When you do your biopsies, you want to make it more likely that you're going to find a cancer, it's there, and you don't want to miss it. So some of the techniques that have been developed over time involve using methods in which there are a lot of biopsies, sometimes up to 20 different biopsies.
Out.
Yes, ouch. That's done under IV sedation. And also using different types of probes to allow us to see inside of the prostate, because we're just kind of feeling the back of the prostate on an exam. But if you use imaging like ultrasound or MRI, then you can see within the prostate, and that way you're more likely getting a biopsy that is going to show cancer if there is cancer and not show cancer if there's not cancer. When these biopsies are done, as I mentioned before, medication is given so that it's a okay experience that generally involves using some numbing medicine in that area and using some form of IV sedation generally to do the biopsies. Once the biopsies are obtained, they go to our colleagues, the pathologists, to be examined under the microscope to see if there's prostate cancer. And after it's examined, there's even more information that's available. And I'm going to ask you, Dr. Simbel, if you can talk about the staging of prostate cancer. That may be something interesting to our audience.
Yes. So, as we were saying earlier, after the biopsy's been completed and the specimen obtained by urologist colleagues has been sent to the lab, and prostate cancer is now confirmed. And now a lot of information is gathered, where there are some specific testing that is done on the specimen, and they come up, the pathology lab colleagues comes up with certain parameters. We already know what the PSA is, and then we already know the pathologist would now tell us something called the Gleason score. The Gleason score is a designation that the pathologist put on the biopsy to help us gather a lot of information regarding decision making in terms of treatment. So for example, for the audience, we're interested in the extent of the cancer within the prostate. You know, we are interested in, is all the elements of the prostate, is it involved with the cancer, which we tend to see in my practice. We are also interested, is the cancer busting out of the prostate and involving other organs around the prostate gland. Like I said earlier, the lymph node, we could get that information through imaging. There are specific imaging that we do. If a patient seems to be lower risk based on the extent of the cancer within the prostate, based on the Gleason score, based on the PSA level, some patients might have to get imaging to look for evidence of cancer spread. You know, there's a scan that we're using now. Back in the days, we used to do a lot of bone scan, basically specifically looking at the bones, given that the bone is a very common area where prostate cancer spread to, and then a CT scan to look at other organs and the lymph nodes. But now we're doing a PET scan, which is specific, looking for elements that could only be seen and expressed by prostate tissue, to keep it simple. And once all that information is gathered, then there's a discussion within, hopefully people like me are not involved, because usually when I'm involved, then it's a little bit more advanced disease. If the disease is localized, then the treatment decision now is going to be between our radiation oncologist colleagues and our urologist colleagues. So, yes.
Thank you so much, Dr. Foot and Dr. Simbo. We're trying to get Dr. Benton back, but let's, for our audience, just to kind of paint this picture. You come on in because you're 47 years old, you're getting your annual physical done. As part of the annual physical, and this is a conversation too that we're going to have about what is the accepted guidelines now for prostate cancer screening across the board in America. You get your blood drawn, and I say, well, Mr. X, as part of your physical today, we're going to do your PSA. We get that PSA done. The PSA is higher than 4. PSA, for instance, is 8. And I call Dr. Foot and say, Dr. Foot, I have Mr. X, the PSA is high, is 8.0. Dr. Foot says, come on in. Dr. Foot sits the patient down, have a conversation, and says, well, we've looked at other things. It does not seem like you have prostate infection, prostatitis. Your prostate is not larger from my rectal exam assessment. The PSA, she repeats it and it's still high. She then decides, we're going to do a biopsy. So a biopsy, like they both have said, is where you, the prostate specimens are taken with a needle going through the rectum to take small specimens from the prostate all around. And she said at times it might take between 12 to 20 small specimens. Everything is numbed up, so it's a little bit the pressure, but not uncomfortable. There might be a little bit of blood in the urine or semen after it's all said and done. When that PSA biopsy specimen is done, you go home the same day. You don't stay in the hospital or in the clinic or in the surgical outpatient clinic like Dr. Foot has, and then they send it out to be tested. The pathologist now sends a report back to Dr. Foot and now says, this is what the Gleason score is, what Dr. Simbo was alluding to. And then based on that, Dr. Simbo and Dr. Foot will now then decide this is high risk or this is low risk. And the question of what the PSA velocity is. And so what should men look out for? Are there specific warning signs that tell us that prostate is in trouble or not?
Because many men who have early stage prostate cancer have absolutely no symptoms at all. We recommend high-risk men, meaning men of African descent and men with family history, start screening at age 40. Earlier if they have symptoms, but clearly don't let symptoms be your only guide to come in to be tested. Once a man has symptoms, clearly checking with a PSA and a rectal examination is indicated, because most men who do have symptoms like decreased force of stream, getting up a lot at night, blood in the semen and in the urine, most of those guys don't have cancer. So we want to figure out what the problem is and get it fixed. Once there's a biopsy that shows that there's cancer, as Dr. Benton alluded, there are means, and also Dr. Simba alluded as well, there are testing that is done to see, is the cancer confined to the prostate? If the cancer is confined to the prostate, then we generally talk about doing treatment to treat the prostate cancer in the prostate, so it doesn't break the shell of the egg, as Dr. Benton described. Under that circumstance, there are a variety of treatments that can treat the prostate cancer in the prostate. Once the prostate cancer has left the prostate, for example, has the shell is broken from the egg and the yolk is coming out, then procedures to just treat the prostate for the prostate cancer are not going to be good enough, because they're not going to get rid of the cells that may have leaked out from the prostate.
Thank you so much. And this will give us a little time too to get back to Dr. Benton. We have talked about on this panel, and I want to just highlight them very quickly, some of the issues why we think for African American men not getting early screening. One of those is structural racism. Another is lack of access. Lack of access meaning we have, before Obamacare, the Affordable Care Act, 20% of black folks in America did not have insurance. 20%, 1 in 5. Since Obamacare or the ACA, that number has dropped down to 10%. And so that's huge. Georgia is also one of those states where we still have not expanded Medicaid, which of course will have expanded coverage for a lot of individuals who are currently still uninsured. So right now in America, we have 10% of black people who don't have health insurance. We're going to be talking about treatment in just a little bit. Even before I start talking about treatment, will they get screening in the first place? Because screening is not free. Today, we have a special program where we're offering free screening, prostate cancer screenings in the PSA, colon cancer mammograms at the Woodruff Park between 10 a.m. to 3 p.m. today. Programs like that are few and far between. So we also talk about the question of mistrust of the health and the health industry, healthcare industry. And Dr. Benton was mentioning the issue of Tuskegee. The study that was conducted just very recently showed that 25% of the black population deeply mistrust the healthcare industry in America. 25%. That is 1 in 4. Deeply mistrust or do not trust the healthcare system, meaning it's because of questions of Tuskegee, it's because of questions of aerator leaks out of Baltimore, out of Johns Hopkins so many years ago in terms of cervical cancer screening. We also know too that those are factors that will make somebody not seek screening early enough when they're not covered, they don't have insurance, they don't have the resources, they mistrust the system, and the system they feel is against them in terms of structural racism. So it's important that we be aware of all of those issues. So let's talk very quickly then about treatment modalities. So we do know that for prostate cancer treatment, once it's diagnosed, the biopsy has been done, the Gleason score came back, and the Gleason score does say, yes, this is prostate cancer. Where do we go from there? We know that there are different treatment options. Once we start talking about Dr. Simba Aduloju, we know we're talking of advanced cases. But between yourself, Dr. Foote, and Dr. Benton, can you give us an idea of where we are in terms of surgical treatment, in terms of radiation, and how things have evolved over the last 5 to 10 years?
Yes. In regards to surgical treatment, there are many different types of surgical treatment. Some of them involve treating the entire prostate gland. Some of them involve treating just the parts of the prostate that are involved with the cancer. In regards to surgical treatment for the entire gland, the most common treatment that's done in the United States at this time is removal of the entire prostate and the tissues around the prostate. That's called a radical prostatectomy. To do that operation, it's most commonly done at this time through looking in through little telescopes that go through the belly button and into the lower abdomen to remove the prostate that way. That's using a device that's called a robot that enables the surgeon to remove the prostate in a way that is easier and potentially more accurate than the more traditional means of removing the prostate, which involves making an incision in the lower abdomen. Another way to remove the prostate is to make an incision in what we call the perineum, which is the space between the scrotum and the rectum. All of these procedures have in common the goal to remove the entirety of the prostate. More recently, there are other means to treat the prostate cancer, particularly if it can be demonstrated to be localized to one part of the prostate. This involves doing a procedure to freeze the part of the prostate that is involved with cancer. That's called cryosurgery. There's other sorts of procedures to include nanoknife, which involves applying electrical current specifically to that area of the prostate and taking care of that too. Another type of treatment for the prostate alone involves something that Dr. Benton's involved with that involves the urologist as well. This partnership between the urologist and the radiation oncologist allows a treatment of the prostate cancer using radiation in a very focal way. That's called radioactive seed implants. What that involves doing is putting small little portions of a material that has radioactive capability into the prostate. As I said before, radioactive seed implantation is a partnership between the urologist and the radiation oncologist, with the urologist actually putting in the radioactive seeds into the prostate as the patient is asleep as a part of an outpatient surgical procedure, with the radiation oncologist having the role to help plan the implantation as well as determine how much radiation is safe to give the prostate. Dr. Benton, are you with us right now?
Can you guys hear me?
Yes, we can. And so we're going to segue to you very quickly in terms of treatment of prostate cancer and how radiation treatment has evolved over the last couple of years, over the last 20 years or so, to where we are. And we would like for you to reflect on the question of, I have early prostate cancer. Is surgery an option for me versus radiation, and what the data currently shows? And as part of that commentary, if you want to mention very quickly the evolution now of proton therapy treatment in form of radiation versus traditional. And I know it's quite a lot that you can, if you can reflect on that in terms of treatment for prostate cancer.
Yeah, when you think in terms of treatment for local, can you guys hear me?
Yes.
So local treatment, obviously surgery has been the mainstay. But radiation, there are different forms of radiation, and we can talk about each of those forms. There's also something called cryotherapy, which is not common, but freezing the prostate. And the FDA approved the technology. I'll give you the acronym: HIFU, high intensity focused ultrasound. But the two mainstay is either surgery or radiation. Now, radiation was discovered in 1894 by Dr. Roentgen. Radiation is fixed in the universe. It has not changed since it was discovered. A proton is still a proton. A photon is still a photon. Beta rays are still. How we deliver that radiation has been tremendously revolutionized. So you can do the traditional radiation, what we call intensity modulated radiation. It comes 5 days a week for 6 or 7 weeks. You can do brachytherapy, which Dr. Foot was mentioning, where we work very closely with the urologist. We insert these radioisotopes and it gives off small pockets of radiation directly into the prostate where the cancer is located. Or you can do a combination approach where you give seeds and plant followed by beam. And more recently, you can use proton. Proton is a form of radiation. It's a positive charge particle. That is, it travels 2/3 the speed of light, and it deposits radiation all externally. And there's something called SBRT, stereotactic body radiation, where you give high doses of radiation spread out over 3 to 4 treatments. And last but certainly not least, there's something called cyberknife, where you insert these GPS coordinates in the prostate, and that helps guide the radiation beam. But ultimately, the end results are the same. Radiation targets the DNA of cancer cells and destroys the DNA. So do you like a Chevy or do you like a Ford? It all serves the same purpose. So the technology is much more eloquent and sophisticated than the technology was, say, 10 years ago. That is to say, we can deliver fairly high conformal radiation to the target with minimum radiation to the surrounding normal structure, so you can get the best possible outcome with the least possible side effects, so it doesn't significantly or insignificantly affect your quality of life. But I think in terms of the two main therapy for localized, I'll let Dr. Simbo Adeloju talk about advanced or metastatic cancer. But for localized, surgery, and most of the surgery now, and Dr. Foot can speak with this, is done robotically. Or you do radiation. And if for early stage prostate cancer, outcome statistically is very similar. It's just quality of life and side effect profiles. Some men will choose surgery and some will choose radiation. You don't have a good or bad choice. You have two superb choices. So men do well, very well, when they're diagnosed early. And I want to emphasize early. And so, yes, there's all sorts of radiation, but ultimately you want the best outcome with the least possible side effects.
Thank you so much, Dr. Benton. And so to put a number here, 99% survival 5-year when the prostate cancer is diagnosed early. 99%. Same thing if it's regional, like Dr. Adeloju mentioned. But if it's the distant, spread beyond the prostate to other organs, that number drops down to 34% 5-year survival. There is no question. The purpose of a conversation like this is to get our men to get screened early. And so if there's any issue with the prostate, it can be diagnosed early and treated. Dr. Adeloju, by the time a patient gets to you with prostate cancer, it's either because Dr. Foot cannot handle it anymore because it's spread beyond, or Dr. Benton says this is now beyond the prostate. It is stage 4. There have been advances too in the last 5 years or so, numerous advances, that this is no longer a death sentence like it used to be. What has changed, and what are you doing differently now from 5 years ago to help those men who may be at a later stage in the diagnosis process?
Right. So overall, when the patient reach the medical oncology clinics, basically it means that the cancer is spread beyond the prostate and beyond that region of the groin. Maybe it's been to another organ. And as Dr. Akintobi alluded to earlier, now the goal of treatment now is changed. The goal of treatment is moved from cure now to controlling the cancer. And I tell my patients this, that the goal is to control the cancer for as long as we can. This is prostate cancer we're talking about. A couple of things is, there's an element called testosterone, and I like to call it testosterone and others. And these are hormones that the prostate cancer really rely on for their livelihood. There are injections, which are always the baseline, I call it, for treatment. Some patients will get injections once a month to keep the testosterone down. Sometimes our urology counterparts are already giving these injections. And as the injections are being given, if the PSA keep going up, which means that now we need more than bringing the testosterone down, then that's when they typically will come to me. Depending on the burden of disease, if the burden of disease is not very high, we might not speak of chemotherapy at that particular time. We might speak of other, because one of the thinking is that as the cancer progresses in a stage 4 state, the cancer also learn how to evade the current treatment that is been, that the cancer is exposed to. So you are blocking the testicles from producing testosterone, but then the prostate cancer now is starting to make its own testosterone without the prostate. I mean, without the testicles. So we have pills that we could use to also interfere with the prostate cancer's own ability to produce testosterone. So that could be an option in a 75-year-old who comes to see me in clinic, who is already getting the injections or taking a particular pill to suppress testosterone, but then the PSA keep going up. But the situation might be different. Same scenario, the PSA is increasing despite this injection in a relatively younger person, 70-year-old, 65-year-old young, whose disease is a little bit more extensive, or who might be experiencing some form of symptoms, i.e. pain. In those situations, we could now talk about chemotherapy. And when we talk about chemotherapy, we're not talking about indefinite chemotherapy in that sense. We could be talking about a limited form of chemotherapy to just kind of help to control the disease without, before going to other options. And what has changed in the last 5 years is we keep pushing the limits, keep giving patients a better opportunity. We have had new chemotherapy that we could use. We've had new treatment that we're using now. There's a drug called Pluvicto, which is an option for patients after they've seen chemotherapy at a certain point. And there are other parameters that makes people qualify for that drug, but, and then there are roles in selective patients who might actually be treated with immunotherapy, even though that role is a little bit limited now. And then there are other research going on, keep pushing the frontier for newer treatment. So there's been a lot of, so I would say overall that the survival of advanced disease continues to increase given some of these newer treatment. But overall, early detection, as we've been saying, is the key.
Thank you so much. And as we kind of wind down this conversation, I would like to go around the panelists here to help me answer this for our audience. Why our specialists don't get together when there's a diagnosis in a patient and the patient has to go from Dr. A to Dr. B to Dr. C to Dr. D. Oftentimes, a lot of conversation and a lot of confusion in that process. What can be done to help to facilitate that process where the patient has a quarterback of their healthcare who can oversee all of what is going on and those conversations being heard. And as we're talking about that, because I'm going to go around, just to reflect based on your experiences, issues relating to side effects, profile of whatever treatment is being offered, whether it's surgery, whether it's hormonal therapy, whether it's radiation therapy. And lastly, so it's 3 questions in one, to look into the future, to see what is in the horizon in terms of research and development. So it's 3 questions in one because we're trying to wrap up in the next 5 to 6 minutes. So we're going to have two minutes each to reflect on those 3 questions. We'll start with Dr. Foote, Dr. Adebayo, and then Dr. Benton.
Well, that's a good way to wrap things up, and I will say that I encourage patients to have a primary care physician, number one, because not everybody does. Sometimes we have people come in who don't have a primary care physician, and we give them recommendations to seek out a primary care physician because we know that that's very important for their health. If you do have a primary care physician and you see any kind of specialist, please specifically ask that specialist to communicate with your primary care physician, because your primary care physician is your quarterback. If you don't have a primary care physician, identify one, get a relationship with them before you get sick, because they're going to help keep you healthy. In regards to what's on the horizon, we're looking at treating localized prostate cancer in a more focal manner to minimize side effects. Side effects being relating to urination and sexual side effects, and being able to manage any side effects that the patient has more appropriately so that the quality of life doesn't suffer when the prostate cancer is treated. That's my comments.
Thank you, Dr. Foote. Dr. Adeloju.
Right. And just like Dr. Foote has said, you need a primary care physician. And if you have one, and the other way to look at it is, in elderly patients, you also need a quarterback within the family. Some of these things are very, very overwhelming for our elderly population. Navigating between the radiation oncologists and the urologists and other appointments that the elderly patients might have. Maybe a son or a daughter should be aware of what's going on, and they could also help to navigate the healthcare. In my practice, I'm lucky enough to work with people who I speak to on the phone. So I feel like we are coordinating very well. When I have patients with Dr. Foote, we're speaking on the phone. And in terms of side effects from our medical oncology standpoint, it's very challenging, because what I've seen in my practice is if a chemotherapy is discussed and accepted and it's being given, I feel like patients, regardless of age, are able to tolerate the treatment very well. Contrary to what they're always thinking that it's going to be a very devastating experience. But then once they start, it's actually very well tolerated for them. The main issue for us is the hormonal treatment. Because the hormonal treatment, especially when you're dealing with a young person, now you're talking about sexual dysfunction and other things. And now we have to weigh managing the cancer versus quality of life. Again, speaking to early detection. Early detection is the key. What's in the horizon from a medical oncology standpoint, there's a lot of research currently going on. We're having new drugs come in the market. Immunotherapy is in a new space in the management of advanced metastatic prostate cancer. So we're very optimistic, for the future. Early detection.
Dr. Benton.
Yes, thanks, Dr. Akintobi. One, having conferences like this goes a long way in starting that conversation. So I want to thank you for putting on this conference. I think we should also end with some good news, because when we hear the word cancer, it's a 2-syllable, 6-letter word, and it carries certain connotations. Not all cancers are the same. They're like human beings. They can have different personalities. Some can be more aggressive than others. So we just need to contextualize this when we're speaking to patients. So over the last 2 decades, the good news is that the death rate from prostate cancer has dropped by nearly 40%. And namely for 2 reasons: early detection, and the armamentarium that we have now to treat prostate cancer is much more vast than we had before. Now, that number will continue to drop because the advancement in surgical techniques, chemotherapy, targeted therapy, immunotherapy, radiation is going to continue to advance. And so I tell patients, it's just like anything else. If you're going to have a headache, you're going to get looked at. but you don't want to wait until you start having symptoms related to prostate. The primary care, such as yourself and many of your colleagues who are really up to date on prostate cancer and how it's affecting this community, are really the key. They're not just gatekeepers, but they really begin to guide patients in the right area. So I know you've been asking us all the questions. I just want to leave by just asking a question to you and some of your primary care physicians. At what point do you trigger related to the PSA referring a patient to a urologist? Is it still 4, or is it the change in the rate, or is it 2 or 2.5? And what are some of your colleagues doing? Because from my perspective, that's where the rubber meets the road. How can we detect these cancer early so men can get the best possible outcome?
Thank you very much, Dr. Benton. So for us in primary care, again, we oftentimes focus very, very much on screening and early detection. There is no question that, unlike with mammograms, where there's a consensus, the goalpost always seems to be moving with prostate cancer. But because for us, with our practice where we see predominantly African American and men of color, about maybe 3/4 of our patients are, we start early at age 40 or earlier if there's a family history to start to do that blood draw for the PSA. So the rate of rise of the PSA is one year, and all of a sudden it goes up to 2 the next year. That's enough trigger for us to say we need to get you to go see a urologist. Even in terms of absolute numbers, 4 and above, yes, and for men of color and black men, 2.5 is the point at which we start to say we need to have a conversation here, because like you alluded to, that 2.5 in an African American man actually means higher if you look at it compared to Caucasian men. So there's no question that the key to all of this, knowing that if the prostate cancer is diagnosed early, 84% will have a 5-year, 99% will have a 5-year survival rate, is crucial. Our job in primary care is to increase the percentage of men diagnosed early from 84% to 99%. And so the question, of course, again, is for those who are not getting screened, is it because they don't have health insurance? If we expand Medicaid, will that make a difference in the state of Georgia? Guiding against mistrust, where people see physicians that they can understand and relate to and share their values is important. Being able to have that and reduction in structural racism. And then other factors too that we know also can affect outcomes of healthcare or cancer. Obesity, physical activity, nutrition that Dr. Foote alluded to, smoking are all things that we have to bring into the mix. We know, and the ACS has quantified, that's the American Cancer Society, that 42%, almost 50% of cancers in America are preventable. 1 in 2 cancers in America are preventable. If we're able to get people not to smoke, 19%, physical activity, 18%. Obesity is another 16%. Reducing certain infections like H. pylori that we know can increase the risk of stomach cancer. Those things are well documented. The question is, how do we translate it into practice? How do we get people now to understand that the question of smoking can increase my risk, and then alcohol use is another one of those that we know obviously can impact on liver cancer without question. So to answer your question just in a nutshell, that is where I see our role in primary care is to present that overall picture, act as the quarterback, and have good referral systems and medical specialists like yourself, Dr. Benton, Dr. Adebayo, and Dr. Foote, that we can collaborate with. We send the patients to you, but we want to know all that is going on, and that we're in constant communication. And I think that communication has to continue to improve. Thanks again to Obamacare, that primary care physicians like us now have access to e-clinical or electronic medical records, where we can look at what is going on within the hospital. Hospital can communicate with us.
So there's still lots of area for improvement, because even now, I don't have to call Dr. Aduloju or Dr. Foot or yourself anymore. I can go to Care Everywhere on my electronic medical records and see all that has happened. And so the affordability for primary care physicians was a key issue that the ACA, the Obamacare, addressed about 10 years ago to make these resources and infrastructure readily available to us in primary care, and of course to other specialists too. So I think this is an ongoing conversation. This has been absolutely fantastic. It's Prostate Cancer Awareness Month, but this is an ongoing talk for us at Shop Talk. We run this once every month. We bring just issues, healthcare issues, to the forefront for us to discuss as relates to the Black community. And we've identified physicians who are willing to share in those conversations and share the expertise and the experiences to help to enlighten our audience and educate our audience. And so I couldn't be more thankful to Dr. Benton, who is not here with us in person, but was able to join us remotely today for his insight and his expertise. I think moving forward, we're going to have a designated segment just to treatment, talking about radiation for an hour. And Dr. Simba Aduloju, who's joined us for the second time, for his time and his diligent work that he does. All his patients love him, and the same thing we have with Dr. Benton. Because of the extra time and passion that they show in what they do. Well, thank you so much, Dr. Aduloju, for your time. And I can't say enough of Dr. Foot. You know, when I send patients to Dr. Foot, everybody comes back with a smile on their face. Well, I love her. She was attentive. And that's just a testament to what you've done for many years in this city. We thank you for your dedication to your craft and for the care of the patients, to both of you, and for making out the time on a Saturday morning to be here with us. As this continues, we're going to have at 10 o'clock this morning a free screening, a healthcare event at the Woodruff Park here in Atlanta. We're going to offer PSAs for men for free, mammograms for women, colon cancer screening with the Cologuard. We're going to do HIV screening, COVID testing, flu vaccinations. We're going to be able to check blood pressure, screen for diabetes and cholesterol. There's going to be entertainment, so there's going to be some music, and there is food too. It's a beautiful day, so if you're able to join us out on the park today, please, you're welcome. But to our panelists, thank you so much for being part of this, and we look forward to this ongoing conversation on Shop Talk and other social platforms to be able to continue to get the word out. Thank you so much for joining us. We'll be here with you again in about 4 weeks when we continue this conversation, just focusing on healthcare issues as it relates to Black America. And we're going to be segueing way a little bit more so to women's health in the coming months, talking about safe motherhood and other issues too relating to the community in general, like obesity, where we know that 2/3 of America, we have the obesity issue, and now that we have some treatment modality that is working well, the GLP-1s, there's a whole area to cover in the coming months. Well, thank you for your time. Have a beautiful rest of the day and a fantastic weekend. Thank you so much.
Now that you heard the facts, apply the knowledge. Contact your doctor or healthcare specialist. Scan the QR code to provide more information on today's talk. See you on the next Shop Talk.